All right, class, I'm going to provide you now the online lecture for week 2, day 2 for perfusion. And our first exemplar is hypertension. And I really want to stress how serious hypertension is and that it should not be taken lightly. It is a cardiac issue, and it's a very, very important public health issue because, unfortunately, without it being under good control, it can lead to heart disease, heart failure, stroke, and renal failure, okay? And a lot of times what we see is when patients do have a cardiac issue evolving, when you look at the patient's past history, health history, you can kind of see that they've had some issues with their blood pressure all along. It is a risk factor for many cardiovascular problems. And why? Because when someone does have hypertension, it does increase the workload of the heart, and it increases oxygen demand. And it also reduces coronary blood flow. And over time, when it's not being controlled, you can have hypertrophy of the ventricles, which can later on lead to heart failure. And over time, it can cause endothelial damage to the blood vessels, which later on causes development of atherosclerosis. And what happens when the hypertension worsens over time, it starts to narrow the vessel lumens and decreases vessel elasticity. We know what people eat, what they consume, can definitely affect blood pressure, meaning that if their diets have a high content of sodium, that will contribute to the development of hypertension, and it also increases the release of natriuretic hormone, which indirectly contributes to hypertension. And also sodium stimulates a lot of the vasopressor mechanisms which cause vasoconstriction. All right, so we really want to get hypertension first discovered, and then, of course, get it under proper treatment. And a lot of times it's just a matter of a person just changing some of their lifestyle habits. Might be as simple as just losing weight. It can actually reduce their blood pressure, especially systolic blood pressure, about 10 millimeters of mercury. So we don't always have to go to medication, but we definitely want to begin to get the hypertension under control. So what I have up here on the screen is your PowerPoint, which I'll go over with you and show you some of the important information from this exemplar that I want you to understand. You know, the American College of Cardiology, along with the American Heart Association, gave us some new guidelines as to what constitutes hypertension. And the definition of normal blood pressure has been lowered to less than 120 over 80 millimeters of mercury. So you start developing hypertension when your systolic blood pressure is above 120, and obviously if your diastolic is above 80. And there's a good table on page 1247 in your Pearson book that talks about the categories of blood pressure for adults, starting off with normal, elevated, and then stage 1, stage 2, and when a person develops a hypertensive crisis. And that occurs when blood pressure is 180 over 120. So anytime blood pressure is over 180 systolic or over 120 diastolic, we consider that a hypertensive crisis, okay? Blood pressure that's anywhere from 120 to 129 and less than 80 diastolic is considered elevated blood pressure. And stage 1 is anything from 130 to 139 systolic, and a diastolic anywhere from 80 to 89. And then stage 2 is anything that is 140 or greater systolic, or a diastolic that's at least 90. So we're trying to give very specific guidelines because we know that this is a precursor and a predisposition for some of the serious disease processes that I just talked about. This constitutes high blood pressure, and obviously it's a major risk factor for heart failure, coronary heart disease, stroke, and renal failure. About 30% of the people out there are unaware of the condition of having hypertension because really there are no symptoms, and 34% of being treated do achieve some kind of control. So let's go back to anatomy and physiology and talk about exactly what blood pressure is. It's the force exerted against the walls of the artery, and with systolic blood pressure, it's that highest pressure at the peak of ventricular contraction, and the average systolic pressure we want to be below 120 millimeters of mercury, and diastolic is the lowest pressure exerted during ventricular relaxation. And remember, if you go back into your Nursing 100 that I talk about with anatomy and physiology, that is when coronary arteries fill as well. So the average diastolic should be under 80 millimeters of mercury. And these are many of the things that determine your blood pressure. Obviously, peripheral vascular resistance, determined by 3 factors: your blood viscosity, your length of the vessel, and of course the diameter of the vessel. And what we mean by that is anybody that might have atherosclerosis, where there's plaque and cholesterol buildup within the inside of the wall of the artery. Obviously the lumen is smaller, so the heart has to work harder to push that blood through it. So that's how blood pressure is affected by these determinants. It's also affected by the sympathetic nervous system, circulating epinephrine and norepinephrine. We know that increases heart rate as well. It's obviously affected by the renin-angiotensin-aldosterone system, and you're learning about that now, especially with the medications that you're studying in Nursing 123, and of course by atrial natriuretic peptide and adrenomedullin, and of course vasopressin, or what we know as ADH, which is one of our hormones from our post-pituitary. So let's look at these factors that influence arterial blood pressure a little bit more in detail. When we talk about the sympathetic nervous system, that has to do with those baroreceptors that are in our aortic arch and in the carotid sinuses, which signal the sympathetic nervous system to increase heart rate and cardiac output, especially if there's a problem like constriction of the arterioles, okay? And so as a result, with vasoconstriction, blood pressure is going to rise, okay? When we talk about circulating epinephrine and norepinephrine, that comes from the adrenal cortex in the adrenals that sit on top of the kidneys, and that's that fight or flight response, having the same effect as the previous factor, the sympathetic nervous system. Your renin-angiotensin-aldosterone system really responds to renal perfusion. So anytime there's a drop in blood pressure, it stimulates renin to be released, and then that renin will convert angiotensinogen to angiotensin 1, which is subsequently converted to angiotensin 2 in the lungs by ACE. And remember that angiotensin 2 is that potent vasoconstrictor, and it also promotes having sodium and water reabsorb back into the vascular system, so that's what's going to hopefully increase vascular volume and hopefully increase blood pressure. So that's a compensatory mechanism that our bodies use, especially when blood pressure starts to drop, and when the kidneys are aware of a decreased perfusion to them. Atrial natriuretic peptide, or ANP, and brain natriuretic peptide, or BNP, are released from the atrial cells in response by the stretching by excess blood volume. And that's what we see happen when our patients have congestive heart failure. which you'll learn a lot more about in Nursing 122. And these hormones will promote vasodilatation and sodium and water excretion that will lower blood pressure. So those help bring down blood pressure, as were some of the other ones I talked about, increased blood pressure. And then, of course, adrenomedulin is a peptide synthesized and released by endothelia and smooth muscle cells and blood vessel. And what it is it's also vasodilates vessels as well. And then, of course, ADH, which I said comes from the post-pituitary gland, will promote water retention and vasoconstriction, and this is what raises blood pressure. And there are other local factors, such as inflammatory mediators and various metabolites that can either promote vasodilatation, which again affect blood pressure. So hopefully that explains those factors a little bit more in detail. And these are some local factors which also determine blood pressure. Atherosclerosis or hardening of the arteries, and atherosclerosis, which is plaque accumulation. Let's talk about the various types of blood pressure, high blood pressure, or hypertension, because it's important to determine what is the etiology of your hypertension, because that's where we can kind of work on ways in which we can get that blood pressure more under control. All right. Primary hypertension has also been known as essential hypertension. It is a persistently elevated systemic blood pressure, and approximately 70 million individuals in the United States have hypertension. And more than 90% of the individuals will have this type of high blood pressure, primary hypertension, which really has no identifiable cause, okay? What they think happens when people develop primary hypertension is it's thought to develop from complex interactions among factors that regulate your cardiac output and your stroke volume resistance, or SVR. And any of these interactions may include excessive sympathetic nervous system overstimulation of a lot of the alpha and beta adrenergic receptors, which cause vasoconstriction and increased cardiac output. Maybe there's some alterations of the renin-angiotensin-aldosterone system, which obviously affect sodium intake and overall fluid volume, and that might be another reason why people develop primary hypertension. Other chemical mediators of vasomotor tone and blood volume, such as ANP, may also play a role by affecting vasomotor tone and sodium and water excretion. Those are some of those chemical mediators that I was talking about. And also it could be from the interaction between insulin resistance, hyperinsulinemia, and endothelial function may be a primary cause of hypertension. And we know that excess insulin has several effects that may contribute to hypertension. Also sodium retention by the kidneys, and increased sympathetic nervous system activity, and obviously hypertrophy of vascular smooth muscle, and changes in those ion transport across cell membranes that I talked about in Nursing 100. So the results of a lot of these interactions really increases blood volume and also increases peripheral resistance, causing the individual to develop hypertension. So we're not sure exactly what is the specific cause, but these could be a lot of factors that play a role in someone who acquires primary hypertension. Okay, the next type of hypertension is secondary hypertension. And this is elevated blood pressure resulting from an identifiable cause, all right? And this accounts for about 5 to 10% of the identified cases of hypertension. First of all, kidney disease is one, okay? Any disease that will affect renal blood flow, that might be the renal artery might have stenosis in it, or any type of renal function such as a infection in the glomerulus of the kidney, renal failure, anything that has a disruption of the blood supply that stimulates the renin-angiotensin-aldosterone system with resulting vasoconstriction, as well as that sodium water retention. And when anyone has any alteration within their kidney function, obviously it's going to affect the elimination of water and electrolytes that lead to hypertension. It won't decrease that vascular volume. The next one is coarctation of the aorta. And what coarctation of the aorta is narrowing of the aorta, which is usually distal to the subclavian arteries. And reduced renal and peripheral blood flow stimulates the renin-angiotensin-aldosterone system and a lot of the local vasoconstrictive responses that unfortunately raise the blood pressure. We have endocrine disorders that occur, and those could be anyone that has an excess amount of cortisol secreted from the adrenals, which may lead to a syndrome such as Cushing's syndrome. Some of the primary aldosteronism problems where there's an excessive amount of secretion of aldosterone, sometimes tumors, and a rare tumor of the adrenal medulla is called pheochromocytoma, which can cause persistent or intermittent hypertension. There could also be other endocrine disorders that affect the thyroid and pituitary, which definitely lead to hypertension. Some of the neurological disorders, especially increased in cranial pressure, could elevate blood pressure. That's a good symptom of increased in cranial pressure. And any disorder that interferes with your autonomic nervous system, such as spinal cord injury, will also affect blood pressure. Drug use, particularly estrogen and oral contraceptives, may lead to hypertension. Stimulant drugs, a lot of your patients that take cocaine or methamphetamines and will increase SVR and cardiac output, which result in hypertension. Some of your decongestants, estrogen and other hormones, corticosteroids, cyclosporines and antidepressants, and long-term NSAIDs will also cause hypertension. And of course, pregnancy. About 10% of all pregnant women will have hypertension as well. And then hypothyroidism. 20 to 40% of patients with hypothyroidism have hypertension. All right. And of course, another one is obstructive sleep apnea, where sleep apnea has an adverse effect on the autonomic nervous system. And because what happens is they have increased levels of plasma catecholamines, and your catecholamines are your adrenaline and your epinephrine. So those are just some causes of why some people experience and develop secondary hypertension. But remember, this one is from an identifiable cause, all right? All right. Hypertension primarily affects middle-aged, older adults, higher in blacks than whites, Hispanics, and in whites, Hispanics more males than females, and in blacks more females. Mechanisms involved in the development, obviously with primary hypertension, no known cause. Kidney disease, most common cause, other common causes as well. All right. these are some of the modifiable risk factors: sodium, potassium, calcium, magnesium intake, obesity, alcohol consumption, and of course things we cannot change called non-modifiable: the genetic factors, age, race, family history. And then the clinical manifestations. Some people are very asymptomatic. They don't really have any signs that their blood pressure is elevated. Or might have some vague symptoms. Maybe they develop things like a nosebleed or things like that. There could be retinal changes, which would be assessed and caught when patients are maybe going for their annual eye exam. Hypertensive encephalopathy is a syndrome that is characterized by an extremely high blood pressure, altered level of consciousness, increased ICP, papilledema, and seizures may develop, but its etiology is also very unclear. Okay. Hypertension can also lead to nephrosclerosis and renal insufficiency, and many times you might see proteinuria and microscopic hematuria develop, as do signs of chronic renal failure. Remember, your African Americans can experience hypertensive kidney disease more frequently than Caucasians do. Hypertension is a major contributor to end-stage renal disease. And patients presenting with a hypertensive emergency may have manifestations as they complain of a headache, may also have confusion, swelling of the optic nerve, which is what we call papilledema, blurred vision, restlessness, and motor and sensory deficits. So those are emergencies that have to be handled immediately. So when anybody has a history of hypertension and they develop these more severe manifestations, they should seek medical attention immediately. And our goal is to reduce that blood pressure and get it below 140. We really want it below 120. There is an algorithm for treating hypertension. Not really one specific test to diagnose hypertension, but we can look at ECGs, which may determine if there's some effect on the cardiac system, such as hypertrophy. Urinalysis will see if there's any effect from the hypertension to the renal system, blood glucose, hematocrit, looking at the viscosity of the blood, and then looking at serum potassium, creatinine, calcium, really identifying whether or not the kidneys are working well. And we would use those benchmarks as a way to determine if the patient has a secondary hypertension. All right. All right. And again, diet is very important when we talk about lifestyle modifications. We see people who have been diagnosed with hypertension kind of use the DASH approach, which is dietary approach to stop hypertension, which is a really good diet, not just for people with hypertension, but it really, talks about limiting, sodium as well. So, and of course, I said before, weight loss of 10 pounds can reduce blood pressure in many patients. Alcohol and tobacco use, no more than 1 ounce of ethanol alcohol a day. Women reduced by half. Smoking is linked to heart disease, and really increasing physical activity. Physical activity is shown to and proven to reduce blood pressure. Regular and aerobic, and of course stress. Physical and emotional stress cause some transient elevations of blood pressure, but the role of stress in primary hypertension is sometimes not as clear as it could be. Remember, our blood pressures normally fluctuate throughout the day, increasing with activity, discomfort, or emotional responses such as, if we get upset about something or we're angry about something. And stress activates angiotensin II, part of that renin-angiotensin system, and angiotensin II then contributes to vasoconstriction and vascular smooth muscle hypertrophy. So you can see the effect that stress does have on the heart. All right. And remember, too, as we begin to age, the incidence of hypertension will rise with increasing age because aging will affect those baroreceptors that is involved in blood pressure regulation. And I've already talked about race, and I've talked about high sodium intake, and we've talked about obesity, especially central obesity, where the weight is pretty much centered in the abdomen. And then we talked about insulin resistance, which refers to that hyperinsulinemia, and that's also linked with hypertension as well. And of course, frequent and a large intake of alcohol. Okay. All right, so that pretty much sums up the main information from your chapters that the chapter you were supposed to read on hypertension, which is our exemplar for the concept of perfusion. All right. All right, what I'd like you to do now is to get out Appendix 23, and we're going to talk about hypertension again and kind of think about some of the information we learned from the PowerPoint and from your reading. So here's a case study where we have Yvonne Genmar is a 42-year-old female with primary hypertension, and right away you should think about what is primary hypertension. I'll let you kind of tell yourself what the answer to that is. She is married to Tom, who has a 17-year-old son, Paul, from a previous marriage. Yvonne and Tom have two children together, Sabrina, 14, and Charlie, 3. And Mr. Genmar runs his own business installing sprinkler systems, and Mrs. Genmar is a real estate agent and a home inspector. Mrs. Genmar spends a great deal of time in her car showing houses and taking the kids to their various after-school activities. Mrs. Genmar's mother has type 2 diabetes. Her father is fairly healthy. Mrs. Genmar has been prescribed several different antihypertensives, but her blood pressure remains elevated. Most recently, she was placed on Catepril, 50 milligrams twice a day, which seems to be maintaining her blood pressure within acceptable limits. So I'm not sure if you've gone over any of the hypertensive medications such as Capaterol. It's a ACE inhibitor just by that suffix of PRIL. So let's look at some of these questions. I'm not sure you'd be able to answer that if you haven't still discussed these classifications of medications to treat hypertension. But the first question is, what precautions would you teach Mrs. Genmar regarding Capaterol and in conjunction with her lifestyle? Really, with ACE inhibitors, they should be taken 1 hour before meals and would have a follow-up for her white blood cell count, potassium, and kidney function, as well as to watch for any edema of the tongue, pharynx, and glottis. And how your ACEs work is they're going to block that one step in the renin-angiotensin system where you have that influx of sodium in water, because we don't want that to happen in the vascular volume because we're trying to get blood pressure down. It also has a vasodilatory effect as well. So you usually start these patients on very low doses to see how they tolerate it, because we don't want to drop their blood pressures too low and have them become symptomatic where they get up from a sitting or a lying position and they're dizzy and develop what we call orthostatic hypotension. So we kind of gradually increase those doses so that the patient is safe when they're taking that, but yet to teach them about signs of blood pressure being too low. So that's how these classifications of drugs work. And that would be a good choice for Mrs. Genmar, because it seems like her blood pressure was not well controlled by some other medications that she was on. And remember, we could also look at her life before, and we're going to get to question 2 to kind of see if there's some lifestyle modifications that we could do to teach her about to also help bring her blood pressure down. So if you admitted Mrs. Genmar to the provider's office before Captopril was prescribed, what interview question would you want to explore in order to determine lifestyle factors that may be contributing to her continued hypertension? Well, we'd also want to know about her diet, because with her being so busy and kind of working out of her car, and she's taking her kids to various places, we're not sure she's eating probably the healthiest foods, and we want to make sure that she's not eating foods that have a lot of sodium in it as well, okay? Does she get any kind of exercise, all right? Is she showing any signs of developing diabetes where she might be becoming insulin resistant? I'm not sure. Let me look. Not sure her weight. Did they talk about that? Let me go through that again. Her mother has type 2 diabetes. This isn't necessarily a hereditary type of disease, but you have a higher incidence of getting diabetes when your parents have had it. We don't really know her how much she weighs. Maybe that contributes to her hypertension. Who knows? We don't have that information. But she has primary hypertension. We know what that's about. We don't have an identifiable cause. And it seems to me that we'd like to know a little bit more about her family history, especially related to cardiovascular and respiratory and things like that, or any type of endocrine problems other than diabetes. That would be important to know as well. And then she probably has a lot of stress as well. Very busy, a working mom. She also has a stepchild that's a teenager. That's enough to cause anybody stress when he's 17 and he's not really your blood son, and maybe he comes to visit periodically. We don't know what the relationship is between her and her stepson, but she has a 14-year-old and a 3-year-old, so there's a wide gap of age between the two children that she had with her current husband. He seems like he's very busy because it's his own business, so he's busy putting in sprinkler systems, and she seems very busy in the real estate business. So, and it does say that she spends a great deal of time in her car showing houses, and in between that, she is also running the kids back and forth. So what nutritional recommendations will you make to Mrs. Genmar to help her control her hypertension? Obviously, her diet is a huge factor. Eating foods with low salt, low fat, low cholesterol, high fiber diet with plenty of fresh fruits and vegetables. So, and plus, getting her to get some exercise, and to kind of get away from all that hustle and bustle in her life, and, maybe get somebody to help with the kids a little bit so she can have a little bit of her own time and downtime, that she doesn't feel like she's constantly on the go and just trying to get from place to place. So you can see that many of us have this kind of a life. I'm sure you all can relate to this with being in school, and some of you have families, so you can understand why this lady would have exhibited, high blood pressure as well. And you want to make sure that she's also tolerating this new medication, Captopril, that she's not dropping her blood pressure too much. So just teach her about how to, be aware of how she feels, that she's not dizzy or anything like that. Maybe this drug is, doing a better job than some of the other ones that she's on. So, just making sure that she's understanding of the medications that she's on and some of the possible side effects that can occur. Okay, so that's Appendix 23 with our patient Yvonne Genmar, who has primary hypertension. All right, what I have here is a model of the heart, and as you can see, there are very defined coronary arteries. And what I want you to look at is to, again, review what these coronary arteries are. because your high blood pressure will affect the filling and the perfusion of these coronary arteries. So if you look at A, that's the post-descending distal right. Your C is your right coronary artery. Your B, right up here, is your left main. Your D is your circumflex. And this F is your LAD, or your left anterior descending. And these are some arteries as well that kind of branch off from some of the main ones. But those are the ones that I want you to remember, because really hypertension will affect the perfusion of these coronary arteries. And again, I want you to review this, because this is stuff that you need to know, especially when you move on and learn about other exemplars, because it's all about the coronary arteries. This is where atherosclerosis take place. This is where we would define whether or not a certain artery is involved in a patient's having an acute MI. So please review this anatomy. It's very important when we talk about the function of the muscle, the heart as a muscle. Okay. All right. What we're going to do now is we're going to move on to these factors that may affect perfusion as well. And you have this worksheet in your packet. And this is why you have to think back as with some of your previous knowledge that you have learned. So how does a heart rate of 140 beats per minute affect perfusion? Well, remember what cardiac output is. Okay, stroke volume times heart rate equals cardiac output. And anytime the heart is beating this fast, obviously it demands more oxygen. And remember, the faster the heart beats, you have a delayed of coronary filling. So it can definitely affect perfusion and affect cardiac output. How about decreasing circulating blood volume? Well, think about it. If there's not enough vascular volume to pump around, it's going to affect perfusion, particularly of the important organs like the heart, the brain, the lungs, and the kidneys. How does a high fever or a temperature of 103.6 affect perfusion? Well, it affects it by increasing oxygen demand and metabolic rate. So the heart has to beat faster to meet that metabolic rate. So that's why a high fever, especially if it's persistent and it's over a long period of time, it could also affect a vascular volume by causing the patient to become dehydrated as well. So that may have the patient's heart work much more intensely to be sure that cardiac output is met. A pain level. Obviously, a pain level of 9 out of 10 may cause a patient's heart rate and blood pressure to elevate because pain has a very negative and detrimental effect on homeostasis as well. How about a loud murmur or thrill heard on auscultation? That would be an abnormal heart sound that we kind of talked about when we were assessing the heart in Nursing 100. And depending on what valve is involved, the patient may have some anomalies or some regurgitation or stenosis involved with those valves in the heart, which will affect circulation and perfusion as well. High cholesterol can lead to plaque and fat accumulation in the coronary arteries, as well as other arteries in the body, not necessarily in the coronaries, but into peripheral vessels as well, which, remember, the effect of perfusion is influenced by the diameter of these vessels. So it could increase systemic vascular resistance, and the heart has to work a lot harder to pump that blood through a smaller lumen. And of course, stress, I just got done talking about the effects of stress on the heart. When different hormones are released, the fight or flight, where you have your catecholamines or your epinephrine and epinephrine, which is going to, again, raise heart rate and increase oxygen demand. All right, so hopefully you can figure those out, but there's always an indirect relationship between some of these occurrences within our daily lives that will affect perfusion and the way our hearts function. All right. Hopefully there's no questions, but if you do, let me know. And then what we're going to do now is look at the next appendix. And this is on appendix 26, so you might want to get that one out so we can go over this together, okay? So during your shift, Mr. Bell Evans, a 64-year-old African-American male patient, presents to the emergency department after collapsing at home. His wife states that just before losing consciousness, the patient seemed confused and complained of numbness and tingling in the left arm and double vision. She also states that his speech was slurred and the left side of his face drooped. He has a history of CAD, hypertension, congestive heart failure, atrial fibrillation, and diabetes. Current vitals are temp is 98.9 Fahrenheit degrees, pulse 91 beats per minute. Respirations 24 respirations per minute, and blood pressure is 182/98, and Mr. Evans has regained consciousness and is aware of his surroundings, but demonstrates right-sided weakness, slurred speech, and difficulty forming words. So let's talk about his presentation and what alterations that we do see in perfusion with him. So what are symptoms of alterations in perfusion does he demonstrate? Obviously, he was confused, which affected perfusion to the brain. He had complaints of numbness and tingling in the left arm, and he also had some eyesight difficulties, stating that he had double vision. Also, let me move this up so we can see this again. His speech was slurred, and of course the left side of his face drooped. All right. So those are very serious situations that occurred, which just definitely demonstrated that he had alterations in perfusion. And look what his blood pressure was, 182/98, and he really was in a hypertensive crisis as well. And he did lose consciousness. So identify 3 non-modifiable risk factors related to alterations in perfusion. Non-modifiable, which means we can't change, what is occurring with this patient. So 3 non-modifiable, can you guys think of one? He's 64, can't change his age. He's an African American, we can't change him, and he's a male. All right. So describe the pathology of a cerebrovascular accident. Is this an example of ischemia or hemorrhage? So what would you guys think would be the problem? Looking at Mr. Evans' history, it looks to me like this is an ischemic stroke just by the symptoms and his history of having coronary artery disease. He definitely has atherosclerosis in the vessels in his brain, causing him to develop this ischemic stroke by just what his symptoms are. Many patients who develop a ischemic stroke will have drooping of the face, paralysis. Many of them do complain of double vision, slurred speech. A lot of the extremities will have numbness or weakness or that sensation of pins and needles. And mental confusion is also very indicative of an ischemic stroke. So question 4 is, what issues can you identify as priorities in caring for this patient? That he doesn't have an extended stroke, that could also involve other vessels, which could affect certain centers or areas in the brain. And you can see that after he regained consciousness, he still is having some right-sided weakness and slurred speech, and he's having difficulty speaking as well. So this may have involved the vessels that takes care of the center and the part of the brain that is responsible for speech. And we want to make sure that the patient, doesn't, can hopefully provide perfusion to the brain. Probably being important to do a CAT scan and an angiogram on the vessels in the brain to see if he has other severe blockages in the brain. Because we do know that with atrial fib, he may have thrown a clot, which is possible if he wasn't on proper medications to prevent clotting. So that's another risk factor that he had. He has a history of hypertension. We saw his blood pressure go up quite a bit, and with his history of diabetes, which affects the integrity of the vessel, can also contribute that to as well. Okay, so he has so many risk factors involved as well. So what are some potential complications that the nurse needs to be aware of? Of course, we have to treat that blood pressure and get that blood pressure down. And, we have to make sure that things are properly perfused. And we are hoping that further progression of his ischemia is not occurring. And then hopefully, the patient does have, further problems with perfusion of the brain and other vessels throughout the body as well. And again, we worry about cardiac functioning as well. And we also worry about renal function, that this high blood pressure or ischemia, he could also have atherosclerosis in his renal artery, which would decrease the amount of blood and perfusion to the kidneys, which could affect his renal function as well. So this is a very serious situation. Again, we have to get this blood pressure, under control, and, make sure we don't see things further progress. All right, so that's, again, a case study on perfusion with Mr. Evans with Appendix 26. All right, now that we've talked a considerable amount of time on hypertension, let's go over some questions to kind of evaluate your learning with this exemplar. All right. Our first question is, the nurse assesses which of the following clients is being at highest risk for hypertension. Number 1, the female adolescent African American. Number 2, the white middle-aged adult who smokes. Number 3, the white woman with central obesity who drinks 2 to 3 drinks a day. And number 4, the African American woman who enjoys traditional cultural food and is above a healthy weight. Who would that be? Think about it. I talked about that. The answer is number 4, the African American woman who enjoys traditional cultural foods and is above a healthy weight. And let's look at the rationale for that. The client at greatest risk, according to research, is the African American woman whose risk is greatest even without the presence of other risk factors. Adding in the risk factors of increased weight and the high fat and salt content found in traditional foods of the culture makes the risk even greater. The adolescent is at lower risk because of age, but lifestyle choices would need to be assessed. All right, so that's question 1. And then, of course, adding to that, white men and women frequently develop hypertension, but are at lower risk than African Americans. However, smoking and obesity would increase the risk for whites significantly. Okay, question 2. A nurse is caring for a client with a history of hypertension who is treated with metoprolol, hydrochlorothiazide, and captopril. The client's current blood pressure is 120/80 with a heart rate of 48. Which of the following is the best action by the nurse? You have to know what these drugs are. Metoprolol is a beta blocker because it ends in OL. Hydrochlorothiazide is a diuretic, and I've talked already about this. This was in our case study with Mrs. Genmar. That's an ACE inhibitor. So the choices are: number 1, administer the metoprolol and the hydrochlorothiazide, hold the captopril and notify the physician. Administer the captopril and the hydrochlorothiazide, hold the metoprolol and notify the physician. Administer all medications and notify the physician. Withhold all medications and notify the physician. And without knowing those meds, it's very hard for you to answer this, but the answer is we would give the captopril and the hydrochlorothiazide, but hold the metoprolol and notify the physician, because your beta blockers will affect heart rate as well as blood pressure. So that's why you would hold that drug, because the heart rate is already 48. So the client has bradycardia. Metoprolol is a beta blocker and causes a decreased heart rate. Neither captopril nor the hydrochlorothiazide causes a decrease in heart rate, so these may be safely given to maintain control of hypertension. When medications are withheld, the nurse notifies the physician of the rationale. Okay, question 3. The nurse is obtaining a blood pressure for a client with primary hypertension. The nurse ensures accuracy of the blood pressure by avoiding which of the following? Placing the arm in a supportive position, bare-armed and at the level of the heart. Measuring the blood pressure after the client has rested for 5 minutes. Using a cuff that covers 80% of the limb. And taking the blood pressure within 10 minutes of the client ingesting caffeine. Now think about back in Nursing 100 when we were taking blood pressures. Things that I kind of went over with you. All right. And definitely the answer is number 4, taking the blood pressure within 10 minutes of the client ingesting caffeine. And the rationale behind that is the nurse should wait for 30 minutes after the client has smoked cigarettes or has had caffeine, as ingestion of these substances causes an increase in blood pressure. Supporting the arm at the level of the heart, covering 80% of the limb with the cuff, and allowing the client to rest for 5 minutes after being seated are all appropriate measures for taking the blood pressure. Okay, question 4. You guys are doing really good. Keep it up. I know you're getting these right. The nurse is aware that reduction of stress is an important part of controlling hypertension. The nurse encourages the client with hypertension to reduce stress in which of the following ways? Number 1, weekly visits to a massage therapist. Number 2, eating foods when angry. Number 3, working from home. And number 4, repressing anger. And the answer is weekly visits to a massage therapist. Now, doesn't that sound nice? All right. Question 4. All right. I'll let you read those, but it pretty much is pretty much an easy question. Okay, number 5. Which of the following nursing diagnoses would the nurse select for the client who has been treated for hypertension and continues to have high blood pressure? And the answers are number 1, ineffective coping, number 2, anxiety, number 3, risk for noncompliance, and number 4, grieving. And obviously the answer is number 3, risk for noncompliance. Good job, everybody. I bet you got that right. And the rationale behind that, with a client who continues to have high blood pressure, the nurse should explore whether the client is adhering to the treatment regimen. The nurse would reassess the client to discover the areas of noncompliance, and ineffective coping, anxiety, and grieving could be potential issues for the client, but noncompliance is the most likely diagnosis until further data are gathered. So great job with that, guys. Okay, I think you've got a good idea about hypertension, what It is where we should see blood pressures at, who's most at risk, some of the risk factors, and things that influence our blood pressure, and what are the manifestations, and what are we going to do about it, just by going over some of those case studies. All right, we'll continue with the next lecture on DVTs.